Well, good morning, everyone who is joining us today, and good afternoon for those who are joining across Canada and beyond. It's my immense pleasure to welcome you to the webinar that we are sharing today on strengthening clinical governance and infrastructure for nursing leadership. We're joined today by some very illustrious speakers, including Dr. Leigh Chapman, Chief Nursing Officer of Canada, as well as other speakers who will be introduced as the webinar carries on. I am delighted to be joining you today. I'm Angela Wignall. I'm the Chief Executive Officer of the Nurses and Nurse Practitioners of British Columbia, BC's Unified Nursing Association, and it's my privilege and my delight to be hosting our conversation today. I'll begin our time together in a good way by acknowledging that I am joining today from the unceded homelands of the Lekwungen-speaking peoples, the Songhees and Esquimalt First Nations, in what is today colonially known as Victoria, British Columbia. This community is also the home to the Métis community of Greater Victoria. And as the Association for Nurses in British Columbia, we serve and support nurses who are providing care in communities across the lands of over 200 First Nations, many different chartered and unchartered Métis communities, and sheltering Inuit. And of course, for those of you who are joining from other places across what is today Canada, I invite you to take a moment to reflect on your relationship with the lands you are on, the First Peoples of those lands, and the ways in which we hold truth and reconciliation at the heart of our work as nurses and as healthcare leaders. Before we dive into the meat of our time together, for those of you who have been on Zoom webinars before, you'll know just how to go about being here together. But for some of you, this might be new. So I'll note that you can adjust your own audio settings by clicking audio on your lower control bar. The chat in this webinar is enabled and it can be seen by all attendees. There is no private chat. For questions and answers, I encourage you to use the Q&A function, which is on the bottom of your screen, to submit questions at any time during the course of our time together. But I'll note that we do have dedicated time for live questions and answers after the presentations from our speakers. Finally, we know you're busy. We all are. And we're really, really glad you're here in the middle of your day. Thank you for taking the time to spend in this conversation. If you need to go, please feel free to do so at any time, simply by clicking the Leave Meeting button at the bottom of your screen. It's my privilege now to hand our conversation over to Terri Irwin to introduce our speakers.
Thank you so much, Angela, and it's a pleasure to be here this afternoon for those of us who are here in Ontario. My name is Terri Irwin, and I'm the Chief Nursing Executive and Executive Vice President of Patient Care Services at Trillium Health Partners, which is the health system that services one of the largest and most growing populations in Ontario, in Mississauga. I'm delighted to be here with my colleagues, Pemasani and Simran Pannag. Mahi and Simran are the co-chairs of our Interprofessional Advisory Council at Trillium Health Partners, and they'll be speaking to you later in this webinar. Of course, very delighted to be invited by Dr. Leigh Chapman, our Chief Nursing Officer of Canada, a dear friend and colleague, and I'm just so thrilled to be here to be moderating this panel today, and of course with you, Angela, with the nurses and nurse practitioners of British Columbia. It's just really an honor. Marion Dowling, the Chief Nursing and Professional Practice and Quality Officer of Health PEI, was due to be here today. So she may surprise us with some late breaking news, but as of now, she won't be joining us for the webinar today. But we would be happy to have her here if she's able to make it. So with that, I'll turn it over to Angela to introduce us to the content for today. Over to you, Angela.
Thank you so much, Terry. And today we're focused on clinical governance and infrastructure, which is one of the dimensions of the Nursing Retention Toolkit. And there is no one better to speak about the toolkit than Dr. Chapman. So, Dr. Chapman, Leigh, can I invite you to step in and share your work of creating this incredible toolkit?
Thank you so much. Merci beaucoup and bonjour tout le monde. I'm delighted to be here. I'm also joining from Ontario or Treaty 13 territory, and just want to take a moment to acknowledge that many of you may be joining from jurisdictions that are impacted by the states of emergency related to the wildfires. So the Nursing Retention Toolkit is something that we launched last March, March of 2024, and it really is the result of the pan-Canadian collaboration with the nursing community from every province and territory in Canada. And it's in fact that collaboration that we're modeling for you here today with representatives from British Columbia and from Ontario and possibly Prince Edward Island, if Marion is able to join us today. So
Marion's here now, Leigh.
Oh, wonderful. So
Yeah,
it is.
I am here. I'm just under the alias of Sherry Langley to get links to work. So thank you for welcoming me.
Wonderful to have you. So we do have some great examples of pan-Canadian nursing leadership and really focusing on this theme of shared governance. And the Nursing Retention Toolkit was really co-developed by nurses across the country who came together at the Nursing Retention Forum. It was held in June 2023. And there was an advisory committee for the Nursing Retention Toolkit to help inform the development of the forum and then the work that followed. So this is really a resource that was created by and for nurses, drawing on evidence-based practice, lived and living experience of point-of-care nurses. And it really is a tool for employers and health authorities with some practical strategies and tools. So you'll see more of that in the next slide. And of course, the toolkit is available in both official languages. So you can see that the toolkit focuses on these 8 core themes. We commonly refer to this as the wheel of the toolkit, and we depicted the themes in a circular format to show that there's no start or end, that we really hope that organizations iterate on these 8 themes and look at how they may impact nursing practice and clinical care within their respective environments. So you can see the 8 themes color-coded, and then in the innermost circle, you can see the core values being respect, anti-racism, anti-oppression, transparency, and accountability that are threaded really throughout the entirety of the toolkit, but certainly throughout all 8 of these themes. And although the toolkit was created in the context of interdisciplinary team-based care, it very much is a resource created by and for nurses, and nurses who participated in the development of the toolkit felt very strongly about that. Here you can see the toolkit again depicted, and you have the QR code to download the toolkit. It is available on the canada.ca website, as mentioned, in both official languages. So you can see here that all 8 themes have a goal statement, and then they are followed by 3 initiatives, with the exception of the last theme, safe staffing practices, which just has 2 initiatives. And I will just hover here for just a moment to say that possibly the top 3 themes that are getting the most attention are flexible and balanced ways of working. You can see that includes flexible work design, scheduling systems, as well as workplace resources and amenities. Another top 3 theme is reduced administrative burden, which is really about redesigning the work environment, digital preparedness, and documentation requirements, and then safe staffing practices, which is around clinical supports and safe staffing frameworks and tools. The purpose of this webinar, and a lot of the dissemination that I'm really trying to focus on this year, is around the themes that are equally important and perhaps getting a little less attention within the toolkit. And so we'll go to the next slide, and you'll see the real right from the toolkit, the description of this theme on clinical governance and infrastructure, that it really is about ensuring nurses have a key role in decision making at the organizational level and are at the forefront of driving driving changes and leading the development of a sustainable health system. So there's 3 initiatives. I won't spend too much time on this, but just to mention, they are structured participatory governance, nursing shared governance, and then nurse-led models of care initiatives and practice standards. The 3 examples that you see here are not exhaustive. They were examples that we cited in the toolkit of these 3 initiatives, but you'll be hearing very exciting, I think, initiatives that are happening in Ontario and PEI and British Columbia on these 3 initiatives. So I will just perhaps mention before passing the baton on to the next speaker, that the toolkit is a resource and a guide, but it really does need to be implemented. And so we're really looking to employers and health authorities to really take up the toolkit and think about how it may foster positive change in the work environment. It has been considered by some of our international colleagues as a pan-Canadian nursing health workforce strategy for Canada. And really it is, there's been great interest in the toolkit, great excitement around the toolkit, but really encourage all of you on the webinar today to share the toolkit, download it, have a look at it, and because there's lots of great examples of things that we can do to improve the nursing workforce in Canada. So perhaps I'll stop there and turn it over to Angela.
Thank you so much, Leigh, for that overview of the work of the toolkit. For those of you who know me, you know that one of the great privileges of the past few years for me has been serving on the advisory committee for the Nursing Retention Toolkit alongside Dr. Chapman. And one of my primary areas of contribution has been this dimension of the toolkit, clinical governance and infrastructure. So before we dive into the incredible real-world examples that Terri and Marion are bringing forward today, I get to share with you a little bit about the very specific theoretical and conceptual places where these ideas come from. When we talk about clinical governance, we are speaking about a framework for accountability and continuous quality improvement. Clinical governance is different from business governance or governance perhaps like a legislative authority like our governments. It is very specific to the provision of healthcare within a clinical context. And it's been described as a systematic approach to shaping, managing, imagining, and improving the clinical context of care. In Canada, we have the Health Standards Organization, or the HSO, and they have drafted a standard around clinical governance for Canada. It is currently still in draft form, but in that standard, they articulate that clinical governance are the mechanisms by which a health or social service organization, and really integrally the people within it, are held accountable for the clinical decisions or the decisions that affect clinical activities. And they note really importantly that clinical governance isn't temporally bound. That is, it's not just for now. It's for now and the future, for existing models of care and emerging and innovative models as well. This particular iteration of clinical governance is often articulated as having anywhere between 5 and 7 pillars. So depending on where you're looking, folks might include different things within the bucket of clinical governance, but generally it is considered to include patient-centered care as a philosophical orientation. It looks at clinical efficacy or effectiveness. It encompasses activities around patient safety, including quality improvement and quality assurance activities. Really importantly, it also includes training and education, performance monitoring, and risk management. And when folks think about governance, they often think about leadership or the policies, processes, the rules sometimes of the organizations that they work within. And clinical governance absolutely does include that dimension of governance and leadership. The version of governance that is included in the Nursing Retention Toolkit is not the only model of governance. There are many different ways of thinking about governance, both clinical and otherwise, across the world and in different sociocultural contexts. This particular version of clinical governance comes from a very specific place and a very specific set of ideas. And those are Western European ideas. So there are many different versions of governance that include different worldviews, including Indigenous governance. This particular articulation comes from something called the Donabedian model. And the Donabedian model is largely considered to be the foundation of quality improvement movements across North America and Europe. It's comprised of three very simple dimensions: structures, that is, our requirements, our processes or actions, and our outcomes. The Donabedian model focuses on systems thinking and posits that care quality emerges from the interaction between human beings and the structures that we create. And really importantly, in the context of Western European healthcare systems, there is a focus on professional autonomy. As we know, nurses are self-regulating, autonomous care providers. We are not just employees or those who implement other people's care plans. And so clinical governance is always in the tension of balancing autonomy of care providers like nurses with accountability. And one of my favorite quotes from this particular theoretical foundation is that systems are enabling mechanisms only. It's the ethical dimension of individuals that is essential to a system's success. So you can hear through the foundations in this particular theoretical orientation that clinical governance is fundamentally always about people. In the Nursing Retention Toolkit, 3 pillars of clinical governance or possible initiatives have been identified. The first is structured participatory governance. And for each of these pillars, I've shared what it does and what it might look like in real life. So what does structured participatory governance do? Well, it ensures that nurses are decision makers, not just interest holders, employees, or those who implement other people's good ideas. It really intentionally positions nurses at both operational and strategic governance tables. Again, we're not just a workforce, we're so much more. It enables decision-making with real authority at different levels within a healthcare organization. So if you're a fan of the IAP2 engagement framework, you'll know that we're going beyond just informing or sharing information, and we're actually giving nurses and those who provide care real authority on what that care looks like. And really importantly, for someone like me, it matters a great deal that we're harnessing the wisdom and the knowledge of nursing. And so what it looks like is representation at board and leadership levels, those nurse-led committee with decision-making mandates that I know we're going to hear a little bit about in a minute, and a really clear connection between governance at the bedside all the way up to governance structures at the boardroom. Nursing shared governance is the second dimension in the toolkit, and it connects the largest group of health professionals on the planet, nurses, by creating structured mechanisms for dialogue and leadership across an organization. And it really enables those direct care nurses to participate in decision makers that affect the care they provide and the environments that they work within. Without these structures, nurses do not often sit at the tables where these things are designed. It might look like unit level or systems level councils. It might look like standardized decision-making that's implemented from the bedside to the boardroom. It really importantly creates circular or cascading communications and clear lines of sight so that people are able to contribute to policies, process, and procedures, that governance and leadership dimension, no matter where they are within the organization, really living that value that everyone is a leader. And really importantly, it captures the work of nursing by measuring what matters, evaluation metrics that capture our labor and capture the impacts of what we do. It also assumes that those things are valuable, and so it pays us for our time. It says that nursing engagement in governance is not just a voluntary activity. And finally, the last dimension is nurse-led models of care. So what this does is, again, centers nurses in the design and delivery, acknowledges our value within systems, and it fundamentally improves the outcomes of patients and communities, as well as systems efficiency. So I know in British Columbia right now, we're in a time of fiscal restraint. Many of us are across the country. These are the kinds of initiatives that help us achieve fiscal restraint. And it looks like NP and nurse-led primary care teams, the expansion of specialist specialty or CNS roles, nurse-led mobile teams, and integrated teams fundamentally led by nurses, because nurses can lead full teams and full clinics. The good news is that clinical governance and infrastructure not only improves care, but it fundamentally transforms how people feel within the context of their care. And that's why it's in the Nursing Retention Toolkit. It is a tool for keeping people at work in our publicly funded healthcare system. I've included a few studies here as references at the bottom. There are hundreds more. The evidence on this is unequivocal, that we increase our policy responsiveness, that we have higher levels of accountability with higher quality health outcomes, higher patient satisfactions, reduced readmission, improved chronic disease management. And one thing that the literature, again, is unequivocal on is that when we enable higher levels of nursing autonomy, we have improved patient outcomes. So you'll see in the Nursing Retention Toolkit, these 3 initiatives. You'll also see incredible examples of how these dimensions of clinical governance are being implemented across the country. And I'm looking forward to hearing the examples we have today. And really importantly for me, clinical governance is the structure that keeps nurses at work by respecting and valuing who we are, the knowledge we bring to the table, and our autonomy as professionals. It's now my privilege to hand the presentation over to Terri to share a little bit more about the incredible work at Trillium Health Partners.
Thank you so much, Angela. And I think I'll keep my remarks short and hand it over to Mahi and Simran. But I will just say that that our shared governance structure at Trillium Health Partners is something that we're very proud of. And I think, you know, you've spoken to the positive outcomes that a strong participatory governance structure can have in many different contexts. And we've seen those benefits at Trillium. And so I'm going to turn it over to Mahi and Simran to just talk a little bit about the strength of our practice council structure and our interprofessional advisory council and our discipline specific councils that really contribute to these outcomes that we've seen at Trillium. Over to you, Mahi and Simran.
Hi, everyone. My name is Simran, and I'm joined by my co-chair, Mahi, and we are thrilled to be here to show how Trillium Health Partners employs shared governance through our councils. So at THP, we have a vision for a strong culture of shared governance supported by a system of councils that amplifies the voices of our staff and empowers them to lead positive change. I wanted to highlight the 2 images on this slide. So the image on the left with raised hands in various colors symbolizes the diversity of thought, experience, and perspective that fuels our culture. Every hand represents a voice being heard. The image on the right highlights the engine of shared governance, where staff drive innovation and improvement while leadership provides support and guidance. Go to the next slide. So the impact at THP. So practice councils offer a vital opportunity for those at the point of care, those that are closest to our patients, to actively shape how we deliver care. They are a powerful tool in promoting a culture of excellence and best practice. These councils create space for open dialogue, reflection, and collaboration. They allow us to ask important questions like, how are things going? What can we improve? What innovative, practical solutions can we bring forward? Most importantly, practice councils reconnect us with our purpose. They remind us why we chose this profession, to provide the best possible care to the patients and families in our community. So our council is rooted in evidence. There is a strong body of literature supporting the positive impacts of shared governance in care settings, including boosting staff engagement, empowering team members at all levels, and greater job satisfaction.
And this is what shared governance looks like at Trillium Health Partners. I want to draw your attention specifically to the two red boxes here. At the top is the Interprofessional Advisory Council, our central council, and below that is our unit-based practice councils. We will dive a little deeper into these councils in the coming slides. I also want to point out the arrow between the two of them. It's pointed in both directions. It's a mutual exchange and not simply a top-down approach. Okay. And these are the faces of the Interprofessional Advisory Council, or IAC. As mentioned, IAC is our central council. It's made up of point-of-care clinicians from across all clinical programs in the hospital, as well as multiple disciplines. We meet monthly from September to June. We actually had our last emotional meeting of the fiscal year just yesterday. Now, what is the purpose of IAC? It's to amplify the voices of those providing direct patient care, to get us involved and provide advice on hospital-wide decision-making in matters that have direct impact on staff engagement, the quality of care, and more importantly, the patient experience. Okay. Here we highlight our discipline-specific practice councils, starting with the Nursing Advisory Council, or NAC. NAC is made up of nurses within IAC, and we serve as the advisory body on nursing practice. It provides leadership on various key issues like policy development, evidence-based practice guidelines, and their implementation. Recent topics brought about during our last year was standardizing the Code Blue response across our 3 hospital sites, work on the behavior safety alerts, and some fun things like our input on Nursing Week festivities. It also serves as a valuable space, a safe space for nursing leadership development, as well as nursing empowerment. Alongside the NAC, we have our allied health practice councils representing professions like OT, PT, social work, and much, much more. They work to advance practice excellence within their individual discipline, again, ensuring that care is both evidence-based, evidence-informed, and aligned with professional standards. Together, these councils strengthen our culture of interprofessional excellence. Sorry. Okay, at Trillium, we have 48 unit-based practice councils, each rooted in an interprofessional model of collaboration. These councils are led by unit-specific point-of-care co-chairs and bring team members such as nurses, physicians, unit clerks, allied health members, all with a common goal of advancing quality of care and patient care within their unit. Now, why are these councils important? They are aligned within the Joy in Work framework, which means that by creating unit-level change, it boosts staff engagement as well as job satisfaction. These unit-level councils are where shared governance becomes real, visible, and actionable.
Finally, we wanted to share our experience as council co-chairs and the impact that shared governance has had on us personally. So I joined the Interprofessional and Nursing Advisory Councils after being encouraged to apply by the previous emergency department rep who ended her term. One unique aspect of our councils is that each year, 75% of members are new. This creates space for fresh voices and new ideas. It's an intentional way to foster leadership development and ensure diverse perspectives are continuously brought to the table. So during my first year as a council member, I focused on understanding how hospital systems work, offering feedback to presenters, and building the confidence to speak up and contribute meaningfully. As I grew more comfortable, I chose to apply for the co-chair role to challenge myself and continue developing my leadership skills. One of my personal goals in taking on this role was to build stronger, more meaningful relationships with my peers and become more confident with public speaking. And this experience has helped me do exactly that. I mean, here I am speaking on a national nursing webinar. How cool is that? Through this experience, I've gained a deeper appreciation for the power of shared governance, not only in improving the way we deliver healthcare, but in empowering individuals to grow, lead, and make a real impact. This experience has truly allowed me to live our council's motto, to inspire and be inspired.
For me, being a co-chair on the Interprofessional Advisory Council has truly been one of the most transformative leadership experiences of my career so far. And Terri is not paying me to say that. It's really given me the opportunity to build tangible skills from facilitating interprofessional collaboration to navigating organizational systems with the goal of leading change. I was able to take these skills back to the front line through my own unit practice council. An issue that we identified through this council was the inconsistency in discharge teaching in post-cardiac surgery patients. Within cardiac surgery, while the length of stay in the hospital is about 4 to 7 days, recovery at home is still 6 to 8 weeks. How do we care for these patients while they're not in hospital, right? So I led a quality improvement initiative to standardize discharge teaching as well as documentation using smart phrases in EPIC, our EMR. I engaged nurses, a physiotherapy lead, a dietitian lead, and one of our surgeons to co-develop clear evidence-based discharge information. And what we found that through this initiative, this not only improved our patient experience, but also helped reduce the variance in care that's provided, helped build confidence among nurses in delivering quality patient care. And we've also seen less admissions through our post-op cardiac surgery discharge clinic.
So finally, we wanted to share a video that was made at THP to highlight the impact of shared governance.
Angela is just going to cue the video here.
Please let me know if you have any issues with the audio as we start.
We can't hear the audio, Angela.
Am I correct in hearing you, Terri, that the audio wasn't coming through?
That's correct, yeah.
Thank you. No matter how many times we trial it before and it works beautifully, one never knows. We'll try one more time.
Change is the only thing constant in life, but what I like about shared governance is I can be part of the change. I can help create solutions that can make change more acceptable, especially on the unit level, and I can be a change agent. I think that's very important as a frontline worker to be able to do that and to be able to influence the change that is happening in the unit. I believe shared governance really is about equity and collaboration between leadership and frontline staff, and it provides the forum to be able to make effective change. It's a time when leaders, point of care staff, patients can come together and think about the problems we're trying to solve, ideas that make for a better way of doing things. It is also a great way to increase choice and autonomy in our programs, therefore increasing joy in work. What shared governance is it shares the decision-making with the people that the decision is going to be impacting, which in turn gives you a diverse perspective on something that you wouldn't necessarily have. Shared governance is about giving point of care staff a voice and valuing what they have to say. The decisions we are making are data-driven, are being made with the patient at the forefront and with the people that impact them the most. Shared governance on our practice council happens two ways. The first one is by soliciting information from frontline staff for change. And the second way is when we give feedback to leadership on policies they want to implement and the changes and input we can provide to that. We're now giving staff the platform to identify their key goals. And in turn, leaders are now supporting staff to achieve their strategic goals. It's about empowering us to hold ourselves to a higher standard and supporting each other to make changes that improve patient care and outcomes. For me, I saw it as an opportunity to be intentional, develop my leadership skills, and make a bigger impact.
Right now for quality improvements, our practice council is working on streamlining the use of our resources. We're working on improving our communication, specifically with transfer of accountability to help us to attain better patient-centered outcomes.
Thank you so much, Mahi and Simran, for that awesome overview of shared governance at Trillium Health Partners. It really is, as I said, something that we're extremely proud of at our organization, and would be happy to connect with anyone across the country to share our experience. From my experience as a chief nursing executive and someone who sits at the executive table in our board of directors, I can say that the strength of the shared governance process really closes the gap between board and bedside. The lines of communication really go both ways and allows our point of care staff to have a voice that goes directly to our board of directors and vice versa. So at this time, I'm going to close out our portion of the webinar, and I'm going to hand it over to Marion Dowling, who is the Chief Nursing Professional Practice and Quality Officer at Health PEI. Over to you, Marion.
Thank you, Terri, and hopefully everyone can hear me okay, because as you may have seen, I've had some technical issues this afternoon. But first off, I just want to say congratulations to Dr. Chapman for pulling together this retention toolkit. It is a wonderful tool, and thank you as well for including me and our little idea on Prince Edward Island for a provincial nursing leadership committee as part of what we can demonstrate around nursing shared governance. So I am here to talk about that and really looking at reflecting on what the toolkit said from nurses across the country. And we have a small piece of this and know that we can still make even more improvements in what we have in place. But really our goal around our Provincial Nursing Leadership Committee is exactly as what was reflected under this pillar in the toolkit around creating those nursing structures to connect nurses and involve them in the decision making that is going to impact their work and their practice. Thank you. A little bit about Health PEI. We are small. We are a single health authority in our province that offers all of the publicly funded health system. We do have, as you can see, sort of probably small numbers compared to multiple hospital systems like Trillium. We do have 7 acute care facilities, a number of publicly funded long-term care facilities, and there are some private as well. And the same with our patient medical homes, which are our primary care sites. You can see our employee numbers there and the number of people within there. There is probably close to 1,600 registered nurses and licensed practical nurses and registered psychiatric nurses, nurse practitioners. So that's our sort of family of nursing. Just a little bit about us. The Provincial Nursing Leadership Committee is really the idea reflected in the toolkit that I'm here to talk about today. And we have established this committee out of our last provincial nursing strategy, which was just pre-pandemic. It ran from 2017 to 2020. And we had a very small provincial nursing leadership group together before the nursing strategy. And that strategy really was an engagement with our nursing community on Prince Edward Island, including our educators, our union partners, and many others, that we wanted to highlight and bring together more engagement from nurses across our programs and service areas within our health authority. So we did establish a broader nursing leadership committee that is really there under my guidance at this point in time, where I sit at the executive leadership team within our health authority, and really trying to bridge that input and feedback in both directions. As you mentioned, Terri, within your program as well, we really are trying to have this committee be there for the agenda is from the committee members to bring issues and ideas forward as much as it is for the leadership of the organization to share changes, policies, and get feedback from that group. As you can see, we're there to support registered nurses, nurse practitioners, licensed practical nurses, the psychiatric nurses, and all those other members of our care team. And we all know we work in a team environment, and all of our partners and allied health supports are also welcome to join our committee and bring forward ideas. One important distinction when we had approval for this broader nursing leadership committee was that we do have the ability to approve nursing policies, standards, and guidelines for nursing practice within our organization. And those are for policies that run across the province and the health authority, and they cross program and service areas. So we've really been doing a lot of work of engaging with nursing within long-term care who may have the same policy or standard of practice as a nurse who works in acute care or in mental health and substance use, etc. So really trying to standardize that and gain input across where we don't have multiple policies and procedures across those programs and services. And the committee has the ability to approve those and endorse them for nursing. We are looking at leading those strategies. We have some specific working groups that were established under our last nursing strategy that have been there focusing on our workforce recruitment and retention of nurses within our system, looking at nursing leadership and education with respect to nursing practice, looking at scopes of practice, models of care, as well as those policy, procedure, and trends in practice that we're seeing. We provide feedback on those provincial and national strategies. It was a great venue for us to engage with nurses from the frontline areas and programs and services to participate in the National Nursing Toolkit consultations. And we do look at those key issues that are coming up. Maybe it's violence in the workplace, a variety of items that may come to this committee to have some discussion and also pass on and contribute to those discussions and conversations of the impact on nursing practice to the leadership of our organization. We do, as I mentioned, look at provincial policy, standards, and guidelines, and we also share those other guidelines down and across our programs and services. The professional development is another big part where we are looking at supporting that and expanding on that and what is needed. And I think the key partnerships and with those other allied health personnel, support staff, physicians, etc., is a big part of this committee. And my little word bubble there is really, I think, what we have striven or are striving toward is to be that place, and we are seeing it happen, where nursing is consulted on strategic planning for the organization, what some new initiatives that might be coming that will have an impact to nurses, what policies might have an impact, other protocols, guidelines, scope of practice changes that are coming to our organization. And they see our Provincial Nursing Leadership Committee as a key partner and stakeholder in engaging in those discussions to allow us time to have feedback from all of our programs and service areas in which nurses are working. So we do have our format is having consensus for our decisions. If there isn't consensus, we tend to need more information and have further conversation and look to the evidence out there on a topic or an issue or determine what our next path is. We do look at aligning our priorities and decisions and ideas with what our health PEI strategic plan and business plans and the priorities of our organization are. And we look to do those things within approved funding and financial resources, or we may seek funding through grants and other means if we need to implement an idea. We do identify the impacts on other service areas or partners within our programs and look to have appropriate consultation and collaboration with those other partners and bring them into our discussions as a leadership committee. And we have those responsibilities for implementing those ideas. That's what we define within our discussion. So we really are a working committee where we don't just do consultation and approving of policies, but we have conversation, discussion, and ideas that are presented forward and sharing of information from other parts of our system as well as across specific nursing practice areas. We do establish some subcommittees and working groups that might be identified for specific purposes. One example I just noted here is a nursing student clinical placement committee, where it was identified that we had some challenges with finding student clinical placements for nurses across our system in partnership with our local colleges and university. And so we really needed to work with them. And so we've established this subcommittee that now meets twice a year, and it's a great avenue for us to hear what is happening in the nursing education programs. Where are there challenges with us getting good placements and really meaningful placements for our nursing students across those programs in our sites, and how can we work together to just improve those challenges or issues that may come up. So that's just one example of a number of subcommittees or working groups that have been established over some time to support the work that or issues that maybe arise and are brought to this committee. Who we are is not Anne of Green Gables, but myself as the role as the chair of the committee. We do have a newly established director of professional practice role that has just been with us since the beginning of 2025. And so that person has now joined our committee. We have a manager of professional practice and clinical policy that supports the work of this group. We have representation from 2 provincial nurse practitioner directors that exist within our organization, one of whom focuses on clinical support and education for nurse practitioners, and the other on some other nurse practitioner direction and supports across our programs and services. And we have representation there, as you can see, from many areas within our system. And we've just identified the number of representation, and we review this on a regular and recurring basis with the committee to see, are we meeting the mark based on sort of the volume of nurses working in those various care areas? And do we have the right people here at the table and representing those nurses who are working in those areas? We also have links with our Executive Director for Quality and Safety for Health BEI, who sits on here. So a very nice linkage there for the impact nurses have and can have on the improvement of care and the quality and safety of patient care, as well as our Principal Nursing Advisor, who was my alias at the beginning of this meeting. We work closely together, as you can see, Sherry Langley, who sits with our Department of Health and Wellness and works closely with Dr. Chapman. So they're a regular member of our committee to really help us link those other provincial, national, other trends and issues or initiatives that are coming, and some of the work that they're doing in the private sector as well. And that's sort of all open to questions, and I'll pass it on then to Angela, who's leading us fearlessly through this, and I apologize for my tardiness in getting on the call.
Oh, Marion, it's such a joy to have you here, and thank you so very much. No matter how you get here, I'm glad you're here. I'm going to hand it now to Terri, who's going to provide us with a few wrapping up remarks before we jump into our Q&A.
Thank you so much, Angela. And I think we've heard some great examples. You've set the stage for us on what clinical governance is really all about. And we've heard some great examples from Simran and Mahi and Marion about how you can operationalize it at the local level, but also at the provincial level as well. And really to drive those outcomes that you spoke about around stronger accountability, improve retention and morale, collaboration, innovation, that really leads to higher patient satisfaction and better outcomes for our patients, which is a goal that we're all working towards. So thank you so much to you, Simran and Mahi and Marion. So we'll now turn it over to our attendees for questions, and maybe I'll kick it off with a question from Gail, which states, how can we invite a change such as shared governance when a system may be in real difficulty with safe staffing constraints in staff time and when constraints in staff time and availability are real? I think this is a very, very important question. Safe staffing is something that we all are continually dealing with. And so maybe I'll start with a few thoughts on this question, and then I'll turn it over to our panel for any additional thoughts. So, you know, really, as a hospital executive, I can't reinforce enough the importance of senior leadership sponsors of governance structures, such as what we have at Trillium through our Interprofessional Advisory Council and our health discipline specific councils. Support of senior leadership is absolutely crucial to the success of these structures. And I would say that, in fact, it is through these structures that we often find creative solutions to help with our staffing issues, and also in terms of leading to innovative ways of structuring our staffing to support outcomes for patients. So maybe I'll start with that comment and just see if there are any other comments on our panel in response to this question.
I will say, like, our time is very protected at IAC and NAC. We're supported by our managers to have that time off. We're on the first Tuesday of every month. We have our monthly meetings from well in advance. So yeah, we're very supported by our leadership in attending these meetings.
Thank you so much, Simran. So we have a second question here. How does shared governance compare with joint problem-solving orientation? Is it the same?
I'm very happy to jump in on that one, as it sounds like a little bit of a conceptual question. And I really applaud Anne for asking this question, because you're definitely doing your thinking work this morning and this afternoon. So joint problem-solving orientation is exactly what it sounds like. It is a collaborative approach to solving problems together. And it really emphasizes that the shared accountability. So there is a lot of parallels. And I think with any philosophical orientation or set of intellectual tools that we're picking up, as I mentioned, it's never singular. There are many, many different ways of looking at a problem, different theoretical tools we can pick up, lenses we can apply. So in this particular instance with the toolkit, we've picked up the tool of clinical governance and really explicitly directed that shared governance is one of the initiatives, one of the key ways that we can move health systems forward. We could have absolutely just as easily picked up joint problem solving and said, this is the tool we're going to use. So neither is better nor worse. You can't moralize them. And you're absolutely right that there are parallels. I would say that there are a few important differences. So when we talk about that, again, sort of the theoretical origins of this particular worldview around governance, it does come from a quality improvement paradigm. So joint problem solving doesn't come from that same place. It has its own philosophical and sociocultural origins. So sometimes where ideas come from can influence how they are played out in real life, the kind of good they create, and also the kind of harm they produce, because these systems are not benign. These ideas are not neutral. They function in the real world. They function in very real ways. So I'll share one example. In an organization that I was previously part of, we were part of creating councils very much like the ones at Trillium Health. And there was a really challenging ethical question about, do we have everyone together, so nursing and allied health, in one council, or do we separate those two things out and acknowledge that there is a need for some distinction or distinction-based caucusing around that? We ultimately decided to proceed with a unified one. And so it's really interesting to hear Simran and Mahi's experience of having a separated one, a distinction-based councils. So again, these ideas play out in the real world in really different ways. And I would be curious if anyone has picked up joint problem solving in their healthcare teams and are using that as a theoretical tool.
Thank you so much, Angela, and really invite anyone to provide any thoughts or comments in the chat as well if they have anything to add. We have a comment from Baljeet around staff engagement and an observation that both in PEI and I think at Trillium Health Partners, it sounds like we have good engagement and how we achieve that level of buy-in. So maybe I'll just start and then I can turn it over to you, Marion, and maybe Simran and Mahi have some thoughts as well. I think it's a bit of a cyclical thing. So by inviting engagement, I think you strengthen engagement. So by inviting people in, point of care staff in to invite their ideas and taking the ideas seriously and circling back on it, you develop trust and engagement through that process. But it takes time and energy. And as Simran mentioned, it also takes resources. And that's where the support of senior leadership is very important, because this does take financial resources to say, we are backfilling you to attend this meeting. And that is how important it is to us that we hear your voice. And so I think, in a bit of a cycle, by inviting engagement, you get stronger engagement, and the circle back on the ideas is very important as well. So Marion, I'm not sure if you have any additional thoughts.
Yes, I completely agree with what you noted, Terri, that the sponsorship from your senior leadership to support these initiatives is hugely important, because that is part of the commitment to having shared governance. And, it is a cycle of engagement. I think we still have a ways to go with some getting really to more patient side nursing engagement in our leadership committee. And maybe that's because we call it a provincial nursing leadership committee. I know when we started, we have a mixture of management, administrative, and more direct clinical support roles that are members to our committee. And what's important to me and the folks in my office who are supporting the group is that we have representation from that practice area. We never like to see no one come. So we have to continuously engage sometimes and offer that a delegate can come if you're not able, and to try and make it meaningful for them, that it is a good use of their time and they feel like they are contributing to improving the work of the organization and the practice of nurses, and what the agenda looks like and the information being shared or what we are reviewing with them is important to them and their practice area. And we continuously have to reinforce that we want their participation. And so I do think we can still take a lot of opportunity to continue to improve that when it gets to be even closer to, like I say, that patient side of the nurses in our system.
Yeah, I also wanted to add, our interprofessional advisory council and nursing advisory council agendas are very robust, and there's something in there for everybody. For example, we have people come in to ask us for advisory on key priorities at THP. We have monthly practice excellence stories, so that empowers our members to come forward with the work that they are doing, to highlight it, share it, so that other people can be inspired to do the same kind of work on their own practice councils on their units. So there's lots, and we also have leadership development sessions every month, working on things like conflict resolution, role clarity, talking about how we can have better team functioning. And we also have our senior leaders come and do leadership talks and talk about their leadership journey, so that people can be inspired to do the same. So we cover a lot of different things, and there's something there for everyone to have that buy-in and be excited.
Great. Thank you so much, Marion and Simran. We do have at least one more question in the chat, but we are at time. So I wanted to turn it over to Angela to close us out. Wow, time flies when you're having fun. So over to you, Angela, to close us out for this afternoon or this morning, wherever you are sitting today in Canada.
Thank you so much, Terri, and thank you everyone who have put questions into the Q&A. You'll see that some of those questions are answered in writing and some were answered verbally. We'll ensure to follow up with each of you who have asked a question to make sure that you have the information that you need. I want to thank our incredible speakers, first and foremost, Simran and Mahi, for bringing your lived experience to this conversation as nurses who are leading these incredible structures that are so critical to advancing quality care and developing our nursing leadership abilities. I also want to thank you, Terri and Marion, for your incredible leadership. Even though I know you are provinces apart and we're on opposite ends of the country, Marion, please know that we are cheering you on from BC in the work that you do. I also want to thank our support staff, Marisa, who is here to support Terri, and the incredible Beatrice, who is our support staff here at NNPBC, for making sure our time together runs smoothly. And I would be remiss if I did not leave the last word to Dr. Chapman, Canada's chief nurse. So Dr. Chapman, perhaps you can have our final words this morning.
Oh, wow. Thank you so much. I'm so delighted that we were able to pull this off, and really want to thank NNPBC, Trillium Health Partners and PEI, but especially Simran and Mahi for participating in this, and for all of the very thoughtful questions from participants from coast to coast to coast. Really excited to see how this gets taken up across the country. So thank you very much. Merci beaucoup tout le monde. Take care.